Hi everybody, this is Stacy Snyder and today we are going to talk about adrenalectomy. An adrenalectomy is the removal of one or both of the adrenal glands, and normally this procedure is conducted either laparoscopic or open. The adrenal glands are also known as the suprarenal glands, and that is because they are located just above the kidneys. The adrenal glands are located below the diaphragm and on top of the kidneys. They are bilateral, which means there are two of them, one on each side, just above the kidneys. The adrenal glands have an outer cortex and an inner medulla. The outer cortex is divided into three zones. The three zones are called the zona glomerulosa, the zona fasciculata, and the zona reticularis. Each zone secretes different hormones. The zona glomerulosa secretes aldosterone, which regulates the sodium and water balance within the body. The zona fasciculata secretes cortisol, which regulates the carbohydrate levels within the body, and the zona reticularis secretes the sex hormones, which regulates the development of sexual characteristics. The medulla contains chromaffin cells, which secrete noradrenaline and adrenaline. The adrenal glands get their blood supply from both the superior suprarenal artery and the middle suprarenal artery. The removal of the adrenal glands are commonly removed due to tumors. If a tumor is found within the adrenal gland and it is 3 centimeters or larger, then the gland that is affected will be removed. If a hormone-producing tumor is found, then the affected gland will be removed, and there are two types of hormone-producing tumors. Those are known as adrenal adenomas and pheochromocytomas. Adrenal adenomas are commonly found within the cortex, and pheochromocytomas are commonly found in the medulla of the adrenal glands. They may also be removed due to pain that can be caused due to enlargement of the adrenal glands. There are 3 different positions that the patient can be placed in for this type of procedure. The patient can be placed into a lateral position, a supine position, or in a prone position. And normally the patient is given general anesthesia with all 3 of these positions for this type of procedure. When applying the skin prep, when the patient is in the lateral position, the skin prep should be applied from the 12th rib, extending to the axilla and down to about 8 inches below the iliac crest. The skin prep should be applied preparing for an upper midline incision when the patient is in the supine position, and it should be extended from the axilla to the mid-thighs down to the table. When the patient is in the prone position, the skin prep should be applied from the 10th rib and extended from the axilla to the upper thighs down to the table. Draping for this type of procedure would include 4 folded towels and a transverse drape. The transverse drape would actually work with all 3 positions, so that would be the only drape that would be needed. Equipment that may be needed for this procedure would be a forced air warming blanket, any kind of padding devices such as pillows, towels, chest rolls, or even padded kidney rests, ESUs, suction tubing, a basin set, blades, sutures, IMs, sponges, hemoclips, which may or may not be needed, just depends on if the surgeon prefers to have that, a needle magnet or a counter. If the procedure is going to be laparoscopic, trocars, cameras, scopes, insufflation tubing would be needed. Just in the case that a transfusion may need to be done, a blood warmer should be ready. The instrumentation that may be required for this procedure would be a kidney tray, a laparoscopic tray, a thoracotomy tray, a vascular tray, a gastrointestinal tray, long instruments, and basic major tray. Now, all of these trays may not be required, but it would be wise to have them handy and ready in the room in the case that one of these pans might be needed. When approaching this procedure in a laparoscopic method, a pneumoperitoneum is created with the patient in the supine position. And once the pneumoperitoneum is established, the surgeon can reposition the patient if he or she wishes to do so. Some surgeons would reposition the patient and place them in a semi-lateral position. Sometimes they will use this position if they want to do a posterior approach. Once the first trocar is placed, the camera is inserted and the abdomen is explored to make sure that the patient is healthy enough to undergo laparoscopic surgery. The procedural steps may differ just a little between the right and left adrenal glands, also depending on the approach that is used. If the right adrenal gland is going to be removed, then the liver needs to be mobilized, and the hepatic flexure of the colon can then be mobilized if needed or preferred by the surgeon. The retroperitoneum is now opened using a scalpel or a bovie along the superior edge of the adrenal gland and continued down the lateral edge of the inferior vena cava. The adrenal vein is dissected and clipped before dividing. Be sure to notify the anesthesiologist prior to dividing if the adrenal gland is being removed due to a pheochromocytoma, because it can cause the patient's blood pressure to drop. The arterial vessels are dissected and divided using a bovie. The remaining tissue is then dissected using a bovie, being careful not to damage the kidney. Once the adrenal gland has been dissected from the surrounding tissues, it is then removed and placed in a specimen cup. The steps of dissecting the adrenal gland from the surrounding tissues and removing it from the body is the same for every approach. The only difference with each approach are the beginning steps of getting to the adrenal gland. The removal of the left adrenal gland is different a little by the right adrenal gland. The splenic flexure is retracted to expose the spleen, and then it is then mobilized to the diaphragm, which will retract the stomach, spleen, and the pancreas, which this will expose the adrenal glands. For the open method, an upper midline incision is made. For the posterior approach, it is less extensive than the laparoscopic or open method. However, it does not allow exploration of the abdomen. The patient is in the prone position for this approach, and they are flexed at the waist, which will allow the abdominal organs to descend away from the retroperitoneum. The incision is closed using Vicryl staples, Xeroform, Dermabond, or the surgeon's preference. This procedure is considered a clean case.